And we're live. Welcome to Brandon Spine Group Live. I'm Dr. Rad. Did you guys see the NFL quarterback Tua Tagovailoa head injury recently? I know it's been all over the news. If you haven't seen it, that's okay. We're going to recap it today as we take a deep dive into the NFL's concussion protocol, some of the nitty-gritty about traumatic brain injury and research. I'm certainly no expert, but as a physician whose life mission is to become an expert in traumatic brain injury, spinal cord injury, neurotrauma is really what drives my interest. I invite you to take this journey in Brain and Spine Group Live every Tuesday, Thursday at noon as we get into interesting neurotrauma topics, have interesting guests, and really just take this live streaming journey through the neuro world together. So I am the CEO, founder of Brain and Spine Group. Brain and Spine Group is a nonprofit organization. Plain and simple, our mission is to improve brain and spine care across the world. We're doing that in a nonprofit organization capacity. So everything we do, from streaming, donations, fundraisers, that we are not, taking that money and doing anything other than trying to make the world a better place. Since many of you are meeting me for the first time, I just want to take this first live streaming episode to kind of introduce myself. Again, my name is Ryan. I am a medical doctor. I did both my undergrad and medical education at Cornell University. I'm also a Marine Corps veteran, CEO of Brain and Spine Group. And in my personal life, the three most important things to me are, being a God-fearing man, a loving husband to my beautiful wife, and just a fun and active father to my amazingly adventurous little 1-year-old girl. And so on this stream, since this is many of you joining us, this is the first time you've been with us, I just want to kind of go over some of the things that we're going to talk about. Primarily we're going to discuss neurotrauma. We're going to discuss research projects, educational innovations that Brain and Spine Group is working on. We'll have guests on the show. And maybe at times we'll take some behind-the-scenes look at some of the operations and administration of Brain and Spine Group as a nonprofit activity. I really want to see engagement from the chat, to talk about new ideas. Maybe we'll crowdsource some research projects. And, this may sound very interesting but overwhelming. If you're not a physician or healthcare worker, you don't have an education in science, that's okay. Part of us doing this live stream is so that we can take that professional barrier down, make technically complex things fun, interesting, and understandable. And, at the end of the day, the point is not for me to be some self-proclaimed expert on social media and the internet trying to tell you, what you should know. Really what I am is somebody who has a means to sort of do research, self-educate, and I want to take you on that journey, let you see into the brain of a professional. When a physician or a doctor or somebody doesn't understand something, they have to go out and learn about it. And that's what this process is really going to be about, is you seeing how we learn and educate ourselves. We're just going to turn the music down a little bit. My production team is giving me notes on the side. Fortunately, we have a wonderful infrastructure with Brain and Spine Group where we can have a production team, but we're still sort of, a small team who runs everything. So if you see me looking off to the side, I'm just looking at another computer monitor trying to get, your comments in the chat read, comments from the production team to make sure we keep things moving smooth as we go along. But again, the purpose of this, stream is really not to be an expert spewing forth knowledge, but really to take you as the viewers on a journey with me as I sort of learn and dive into, you know, issues related to neurotrauma, education, overall brain and spine health. Again, we're a nonprofit organization, so if you like this content, you like seeing all the education that we do, the live streaming, you know, we'll talk more about research projects. We're going to come up with ideas for new research projects. If you want to support these endeavors, you know, you can go to our website, brainandspinegroup.org/support or /donate. You can donate, you can like, subscribe to our channels. If you don't have the means to donate, that's okay. Following us, helping get our content, our videos out there is just as important. So if you want to do any of those things, go ahead, head over to our YouTube channel, our Twitch channel, Instagram, Twitter, wherever you want to find us, wherever you get your social media, we're there. So go ahead, like, subscribe, donate, support what we're doing, and we assure you as the calendar turns to 2023, the activities of this organization are going to get more robust and more exciting. So let's get right into it. Traumatic brain injury. It has recently been in the news with Tua Tagovailoa having this really bad head injury. Before we get into the details, why don't we just go ahead, for viewers that have not seen the actual injury, let's watch some video clips here. Sadly, we're going to pull them up on YouTube and probably have some clips here. This is
your granddaughter's going to love it.
We are not a sponsored stream by USAA, but USAA, if you're out there, you're listening, I am a veteran, I use your services. If you want to sponsor our live stream, go ahead and send us an email at stream@brainandspinegroup.org.
community.
Alright, so this is the initial injury.
Tua Tagovailoa throwing off his back foot with the rush in his face there. Jalen Waddle makes the catch. Penalty flag comes in, and Tua Tagovailoa was roughed at the end of the release.
So I love how they're showing a replay of him getting roughed on the release, and then the camera follows the ball and not the injury.
Pass rusher came on top of him there, and
here we go.
Tagovailoa suffered some type of an injury on this play.
So honestly, not that bad of a hit on the initial injury. Now, obviously, this gets more complicated because there's a second injury. There's a lot of questions surrounding how did he even make it back on the field to get to the second injury. And as you'll see, the second injury is much worse. But honestly,
Bridgewater in the game
when I look
right
at this
now,
injury recap,
it's
not that bad. But then obviously you see here, he starts stumbling. So something's clearly going on. When we get into a little bit later on, I'm going to talk about some of the criteria of diagnosing traumatic brain injuries and concussions. And immediately what you see here is what is documented as a red flag symptom. These are what we call motor disturbances. Somebody clearly hit their head. It doesn't look like that bad of an injury. Honestly, if I saw this injury from the sideline, I probably wouldn't, think too much of it. It's the fact that he gets up and he has with these motor disturbances, which are red flag symptoms and head injury. And it does make you kind of wonder, he must have hit his head much harder than it appears, because if you back it up, this really doesn't look like that bad of an injury initially.
This play,
we have back a little bit further.
Suffered some type of injury
on
this
trips,
play.
Falls backwards.
We have
just doesn't
Teddy
catch himself and
Bridgewater
smacks his head
in
on
the
the
game
turf. That's an
right now.
unfortunate injury.
Tagovailoa, oh boy.
Alright, so now, basically, he comes off the field. He gets evaluated by an independent evaluator from the NFL. I don't know. Actually, hold on. I have a feeling. Did we just play that whole clip? We didn't even show the clip, did we? Hold on. I apologize. We're working through technology for the first time. Let's go. Let's change the screen here. There we go. Now you should be able to see it. So I just went through all that commentary on a video you couldn't see. I do apologize. Let's just speed back through it.
Came on top of him there, and Tagovailoa suffered some type of an injury on
so this is the injury. It doesn't look like that bad of a hit. Falls back, hits his head on the turf.
Right now.
And then if we speed up here, this is where you start to see motor disturbances.
Oh my
goodness. What I would say is injury seemingly somewhat disproportionate to the mechanism, which is not uncommon, but it's sad to see. So now let's go back to it. Let's find injury number 2. So he goes off the field after this injury. He gets evaluated by an independent evaluator and ultimately was deemed well enough to come back into the game. Let's mute this for a second. I'm going to play the ad on the second video off stream, and then we'll pull it onto the stream for you once the ad's done. So he gets evaluated by an independent evaluator. They deem him healthy enough to come back into this game. They finish the game with no further injuries. They go back to practice, and then now we fast forward a week to the next game when a player who had just had a head injury resulting in motor deficits was subsequently cleared by an independent evaluator to return to play, and now the following week undergoes a more significant injury. Let's take a look at this injury here.
Halftime. To a rolling left with the grain, and down he goes, slung down in his own 48-yard line. Josh Tupu, and
Okay. Let's back this up. This hit looks much worse. And actually, the first time I saw this one, I didn't even think it was that bad. When you watch it in full screen, you can like really see the slingshot effect of his head hitting that turf. And this is where you get into the actual mechanical things that result in serious head injuries. So, traumatic brain injury is the result of acceleration forces. Now, I'm going to make just a brief clarification, because people use this term all the time. They'll say, oh, there's a deceleration injury where, there's a speed, an object is moving and then it comes to a sudden halt. And they say, oh, they decelerated very quick. Deceleration is not a thing. You have negative acceleration. I want to make my physics professor from undergrad very proud. You have positive and negative acceleration forces. In this case, right, what's happening is, and let's stop for a second and think about the actual mechanics of a head injury. So your brain is not sitting inside your skull, taking up all the space inside your skull. In fact, actually, the skull, there's a lot of space between the actual hard bone and the brain itself. The brain is actually kind of floating around inside the skull, inside a pocket of fluid, what we call cerebrospinal fluid. Right? Cerebro meaning brain, and spinal meaning spine, because it's fluid that connects to both brain and the spine. Cerebrospinal fluid. It's basically clear fluid, wraps around the outside of the brain, it has pockets inside the brain, and basically the brain just kind of floats very comfortably, right, inside the skull. And as you walk around, the brain bounces a little bit and it's cushioned by this fluid. But you can imagine that if your brain is moving and then all of a sudden the skull comes to a sudden halt, the brain will shift inside. It basically slams into the hard bony part of the skull. That is the mechanical visualization of how a traumatic brain injury happens in a very succinct understanding. Obviously, it can get more complicated than that, but for the sake of understanding how a traumatic brain injury actually occurs, that's the gist of it, right? So when you're dealing with extreme changes, negative changes in velocity, right? Because acceleration is a change in velocity, right? So negative acceleration, high amplitude negative acceleration, or, for non-scientists, non-physicians, the simplest way to think about it, really extreme abrupt halts causes the brain to smash into the inside of the skull, and that's what causes traumatic brain injury. So even though actually, if you look at it here, you might think the initial impact's not that bad of the injury.
Halftime.
Right? He comes in, he gets wrapped up, and he just kind of slowly gets slung down to the ground, right? He didn't get hit like a Mack truck and just plowed down. But it's that whipping motion of bringing him around, brings the head down, and you get this sudden negative acceleration as his head hits the turf. So when I first watched this, let's see if they've got another view here of the actual injury. I think it was like right around here. Right? I saw this in slow motion. I was like, oh, he actually landed on his elbow. He hit his back first. But the reality is, I think sometimes don't overcomplicate the replay. Just watch it in real time. Right here. He gets slung around, whipped back, head into the turf. I mean, the back of the brain basically just collided with the back of his skull at an extreme speed. All right, so thank you for the likes. We do have notifications enabled, so as we like, subscribe, we'll call them out, and thank you all for your support of the stream. All right, so now we've got a guy who had a somewhat minor injury, exacerbated by motor disturbances on the initial injury. Cleared when, in hindsight, you say, oh, it probably shouldn't have been cleared. He comes back, now he has a subsequent injury. And at this point, this is where people start going, start to realize, even it doesn't take a doctor to realize, like, this is a serious injury when you look at kind of how things play out from here. You look at his hand positioning, very unlikely he's conscious. I think here's actually a good view. You can see his eyes are closed. He's very much in what we would call, we've crossed at least into the category of moderate traumatic brain injury, right? Concussion being your typical mild traumatic brain injury. And then you have, traumatic brain injury increases in severity from mild to moderate to severe is how we generally categorize traumatic brain injury. In this case, it's pretty clear we're crossing into the territory of a mild traumatic brain injury. In fact, you might even say we're not even dealing with a concussion anymore. Concussions are typically considered mild traumatic brain injuries. If we have diagnostic criteria, which I'm going to talk more about in a little bit, saying we're crossed into the realm of moderate traumatic brain injury, I wouldn't even say that you're dealing with a concussion. So, but obviously this prompted a lot of introspection. People say, how did a guy like this get through the concussion protocol? How did a guy like this return to play so soon? And I guess apparently the independent evaluator from the NFL was subsequently let go. I don't entirely understand how their contracts work or what their employment status is, but the NFL's concussion protocol subsequently underwent revision. And so we are going to look at the actual protocol today, but before we look at the NFL's specific protocol, which I've reviewed briefly, a lot of the material I've put together for the live stream, I have reviewed it to make sure it's useful and helpful, but a lot of stuff I have not gone through in detail because I want to do that live so we can, really break it down and discuss it rather than me having just read it ahead of time and give you this sort of prefabricated impression of what I think. So in order to look at the NFL's concussion protocol, I wanted to talk a little bit more about what TBI is in more of a general sense. That way, for those of you who are not physicians or medical students or healthcare professionals in any way, you have some sort of background to sort of understand what is the NFL doing with this concussion protocol and how is that actually making the game safer to play, or is it failing to make the game safer to play? Those are sort of the questions we want to ponder. So let me pull up one of the first articles I had found here. Let's pop this over here. Let's go to our screen share here. We should have this up here. Let's just confirm everything looks good. So this is actually a report on TBI that was given to Congress, I think what was the year of this? This is an important part when you're, because everyone says, oh, I did my research, right? Everyone knows that person out there in your life. This is not a political commentary in any way, but everybody out there knows that person. They're like, oh, I did my own research, and they did it at like liberalkaren.org or like the Trump Daily, and you're like, okay, really? Is that reliable research? Considering the source of where your information is coming from is the single most important thing when you're researching anything. So, and when was it published, right? If you're looking at information that was from 20 years ago, it might not be applicable. So always looking at information through the lens of when was it published and where is it coming from. And so this is a report given to Congress in 2015. There's a couple things here I thought were pretty interesting. Let's just start by looking at, how they define, let's go back to the top. What did I have? What did I want to look at here? Was where are Or let's see here. Where did our table of contents go? Injury severity classification. Let's see. Oh, right. This is the graph I wanted to look at, right? And so we talked about the sort of the mechanisms of traumatic brain injury. You start to kind of understand. We put them into categories of mild traumatic brain injury, which are pretty much where all concussions fit. Then you have moderate traumatic brain injury, severe traumatic brain injury, which are typically where you have patients that end up in the ICU with long hospital stays. But you have to, the first thing we ask ourselves when thinking about approaching a problem in research is really like, how many people does this affect and how big of a problem is it? And TBI is one of those problems that affects large numbers of people. I mean, these are the numbers in the United States. This is number of TBIs per 100,000 people. So basically the total number, you have about 824 TBIs occurring for every 100,000 people in the population. And that's just in the United States. I believe there's, let's see, I think there was here we go, an article from the Journal of Neurosurgery a few years ago. Let's see, pull this up here. Let's make sure we got the correct screen up. Yeah, we can view this here. So Journal of Neurosurgery, very reliable journal, one of the landmark key pillars of scientific information in the world of neurosurgery. They published in 2018 basically an estimation of global incidence. So incidence meaning total number, basically, of how many TBIs are there in the world. And they're saying somewhere in the ballpark of 69 million each year. And obviously the things that cause these are generally, higher numbers in countries with less infrastructure. I should back that up. There's different mechanisms of what causes traumatic brain injury based on the part of the world that you're in. Traumatic brain injury is a big problem in lower and middle income countries because they generally don't have well-regulated mechanisms within their society to prevent traumatic brain injury. And traumatic brain injury, as you've seen the numbers in the United States, affects tons of people, even here where we do have a lot of things like seat belts and bicycle helmets and motorcycle helmets. These things do far more than we probably realize to reduce the numbers of injury in the United States. However, countries without that type of infrastructure, you go down, the Dominican Republic is a place that my family and I go to regularly, and we, help on missions trips in, non-industrialized parts of the country, and you just see people up and down the streets constantly on motorcycles without helmets. That type of regular behavior is what leads to higher incidences of traumatic brain injury. The point is, traumatic brain injury is a huge problem globally. However, it's not something that we have a ton, I would say an equal amount of research trying to combat and work on issues related to traumatic brain injury. And so to answer the question, that's why we care about it, right? I mean, it's a problem that affects tons of people, and it's a problem that doesn't have great solutions. And so naturally, it's a problem that warrants the attention and the resources of not just physicians, but researchers, public health people, the general public, people advocating for, better things to address traumatic brain injury, because, it's a very serious problem that affects people in a very deep way. And so that's why I think it's important to really think about why we care about, dealing with traumatic brain injury. And on that note, we have to then think about, as we've already started alluding, how do you actually deal with these issues, right? And it's hard because actually, there's an article here that I was reading just this morning. I think it was very fascinating. They said they estimate about 8 million TBIs occur. Oh, I'm sorry, these are just mild. So basically 8 million concussions are happening in the United States. So when we looked at those previous numbers, right, and we were like, oh, there's 100, all these, that's all traumatic brain injuries, severe, moderate, and mild. Now we're just looking at mild. They're saying roughly about 8 million of them happen in a year. But the CDC only reports about 1.3 million. Now, again, not a political commentary, but this is not the first time, I'm sure, where the numbers from the CDC don't exactly match reality. And that's because the CDC has limitations on where they get numbers from. If they estimate 8 million people have a mild traumatic brain injury in the world, but only 1.3 million of them actually show up for care, it's hard for the CDC to collect numbers on that. But that just goes to show that there's tons of just regular people out there that fall, they hit their head, they get a concussion, and they never see a doctor about it. And hopefully some of them are okay, but some of them could develop more serious complications from that. So, I just had a good friend tell me the other day that they, were out walking their dogs and, the dogs tripped them up, they fell, they hit their head, and they kind of don't even remember what initially happened. And I told them, I was like, you have a concussion at the least. I hope it's not any worse, but, then the real world questions start creeping in. Well, it's 9 o'clock at night. Do I want to go to the emergency room to wait there till midnight and be told that I'm fine? And the reality is no one can tell anyone that they're fine. And this is why traumatic brain injury is such a challenging problem as doctors and healthcare providers. You want to help people, but it's such a challenging problem to really get people to take seriously. But let's bring this back to the NFL. The NFL, while the reasoning for them taking concussions so seriously is, largely probably because of the players' union and all these things where, they're pushing for it. But one of the most important things that we can do is utilize the NFL and the military as essentially controlled populations, right? Populations where they're being monitored before the injury occurs, so that way you can get to the point of the injury right when it happens, and you can not just intervene, but you can study that disease process from the moment it happens until we go down in the future. Whereas if you use the general public to try to study these things, you get to the point where, you miss so many people that it just makes it very hard to actually make real improvements on these types of issues. So let's kind of transition here and get right into the actual traumatic brain injury protocol of the NFL, the concussion protocol. I've looked at this briefly. I have not gone through the protocol in depth because I really thought that this was something I wanted to go through in real time. Okay, so we'll see kind of what we come up with. Let's get our screen shared here so you can see. So this was amended October 8th. So I've got to imagine what we're looking at is post-injury, post-TUA injury amendments to this protocol. And I'm sure any changes were as a direct result of that situation. All right, so let's kind of, yep, obviously concussion's an important, it's a very key injury for professional football players, yada, yada, yada. How does the NFL define concussion? It's defined as sports-related concussion, traumatic injury induced by biomechanical forces, as we discussed. SRC caused by direct blow of the head, face, or the body. Typically, there's a rapid onset, short impairment of neurologic function. So this is exactly what we saw. Short impairment of neurologic function. There was actually, let's pull up where was it here? That's the report to Congress. Oh, here. Is this it? No, that's not it. Let's find there was a really good red flag thing that discussed the red flags of traumatic brain injury. I wanted to share with all of you. Let's see if we can find it here. Oh, here it is. It was in this print article. So this print article, you know, says that, you know, list red flags, right? These are the things where even if an injury doesn't look that severe, but you see these things, that should make bells and alarms go off right away that the brain injury is more severe than it possibly let on. Altered consciousness, asymmetric pupils, seizures, vomiting, double vision, headaches that get worse, severe disorientation, slurred speech, unsteady gait. This is what I was trying to point out in that injury video, the initial injury that didn't even look that bad, that Tua had. And then obviously weakness or loss of sensation in part of the body. You know, these red flag symptoms are there for a reason. And so basically basically the NFL is saying if you exhibit any of these short-lived impairments of neurologic function, which are basically those red flag symptoms I just listed, you are diagnosed with a concussion or traumatic brain injury per the NFL's definition, which is good. Let's see. Functional disturbance rather than structural injury, no abnormalities seen on standard. Okay, so basically what they're saying is just because you have a clean CAT scan doesn't necessarily mean you don't have a traumatic brain injury. That's good, because actually a lot of mild traumatic brain injuries you don't see anything on the CAT scan initially. And the CAT scan being a form of imaging. I don't know, let's just look at a head CAT scan for our non-healthcare professionals. You can see basically what it looks like. Here's a very basic brain CAT scan. So this is how somebody goes into a CAT scanner. It looks like this. This is maybe a little bit of an older picture, but you can imagine the slices of the image are going through the brain up and down like this, right? They're slicing through the brain like this. So when you look at a CAT scan, this is a CAT scan with an epidural hematoma here. You know, when you look at the CAT scan, you're looking from the patient's feet up. And so you sort of just see a slice through the brain, and you go, you know, you can slide up through, and, you know, you'll very often, you know, as a physician, you'll look at tons of these CAT scans for patients with injuries consistent with traumatic brain injury, and very often they look completely normal. So this is good. The NFL is basically saying, like, you cannot rely on imaging alone to rule in or rule out a traumatic brain injury. Loss of consciousness. Yeah, key part. Even if there's a loss of consciousness is associated with severity of outcome related to traumatic brain injury, meaning the longer you have a period of loss of consciousness, you know, for patients with severe traumatic brain injury, that period of loss of consciousness can be days to weeks. Whereas somebody with very mild traumatic brain injury may have had a brief split second of loss of consciousness. That duration of loss of consciousness is generally associated with severity of the injury. And then let's see. Clinical signs and symptoms cannot be explained by drug, alcohol, or medication use. Other injuries, cervical injuries, peripheral vestibular dysfunction, or other comorbidities. Okay, so this statement, very applicable for a trauma physician evaluating a patient in the hospital, right? Is the patient non-responsive, or is he just drunk, right? You can't determine whether or not a patient does or does not have a traumatic brain injury or is slurring their speech because of a traumatic brain injury if they are drunk. So you basically have to sober the patient up before you can really truly assess the degree of their injury. Considering I don't think there's too many NFL quarterbacks out there playing drunk or under the influence. I don't know. I don't know what goes on in the locker room. This is probably not as significant. However, you know, you do think you want to make sure none of their neurologic symptoms are related to a spine injury. That would be confounding or sort of muddying the water when you're trying to look at the picture of a brain injury. So let's see. Potential concussion signs observable may include loss of consciousness, fencing posture. This is a really important piece of information. We're going to come back to that. I have a couple things I pulled up about fencing posture. Slow to get up from the ground, return to play, following a hit to the head, motor coordination, balance problems, blank or vacant look, disorientation, behavior change, aggressive, blah, blah, blah. Okay, these are all, makes perfect sense. Amnesia, clutching of the head after contact, interesting. Visible facial injury, potential concussion symptoms, headache, dizziness, lightheadedness, balance, coordination difficulties, nausea. Let's see. Oh, hold on. My team is telling me you guys are having a little bit trouble seeing. Let's see if we can zoom in a little bit here. That way you can see better. Where's our zoom here? Here we go. Hopefully that's better. Let me know, Carlos, if this looks better for everyone. Okay. Potential concussion symptoms, headaches, dizziness, lightheadedness, balance, coordination, nausea, cognitive slowness, light and sound sensitivity, disorientation, tinnitus, vertigo. These all kind of fall into the red flag symptoms. Clearly agree with all this stuff. I don't think it's very enlightening. So, honestly, I don't know how much of this information about basically their preliminary diagnostic criteria did or did not exist in prior versions of the NFL's concussion protocol, because clearly we're looking at the revised version. But having watched those videos, now looking at the NFL's concussion protocol, I just don't see any potential area where anyone could have missed based on Tua's first injury. Whether or not, in my mind, there's no doubt that there's a concussion, at the very least a mild TBI. So that being said, I'm saying that now looking through the lens of the brand new protocol, maybe there was some things blatantly missing from the prior NFL protocol. This is obviously amended on the 8th, so after the injury. But let's stop for a second. And actually, let's just keep going. I do want to talk about this idea of fencing posture, because I saw the fencing posture was initially mentioned in one of the first articles I read about his injury. I think it was a CNN article. Let me pull it up here. Yeah, it was a CNN article. So, blah, blah, blah. It was more about, terminating the unaffiliated neurotrauma consultant who, if they were working off a version of the protocol even remotely close to what we just read, even though we haven't even read the full protocol, that seems very reasonable to me, because clearly they missed very blatant red flag signs. I don't know. I don't want to sit here and play Monday morning quarterback, no pun intended, because obviously that's very easy to do with all the information in this person, this neurotrauma consultant. I don't even know what that means. Are they a medical doctor? Are they a physical therapist? Are they, I don't know what types of people they employ as neurotrauma consultants. It's kind of a very vague term. But whoever they are, they definitely miss red flag symptoms that are very clearly documented in the neurotrauma literature. May not have been documented in the NFL's concussion protocol, but red flag symptoms definitely documented in the literature. So in this article, they're basically saying, he left the game against the Buffalo Bills, he came back, and they thought it was just a back injury, not a head injury. I mean, maybe you could attribute his motor symptoms to a possible back injury, but I don't know. That's too hard to tell. I don't know, in the sense of, clearly I'm looking at it through a very biased lens right now, knowing sort of all the information after the fact, but to me it seems kind of hard to have justified this as a back injury. Oh, this is the part I found. CNN's chief medical correspondent, Dr. Sanjay Gupta, a neurosurgeon clearly very famous, said fencing response can be linked to brain injury. So at first when I saw this, I was like, a fencing response? This doesn't seem like a fencing response to me. And actually, where you hear about fencing responses, so there's actually this thing called fencing reflex that infants do, where they basically hold one arm out, one arm's bent, and they kind of look towards their arm. It's a sign of brain development that you generally want. They're motor signs that you see a child exhibit as their brain develops and becomes more mature. They hit all these different milestones. Very early on in age, this fencing pose is a milestone that you generally expect children to hit and display as their brain develops. Now, when the brain becomes injured, it's very similar in the sense that they almost like revert to this what's the word? Primitive reflex. But I didn't understand it very well, so I spent a little time reading about the fencing response over the last week, kind of in preparation for today. One interesting article that I found, I'll pull it up here. Let me just make sure okay. Let's see if we can zoom a little bit. Oh, that's not the right page we want. Let's see if we can get that. Go a little bit bigger. Okay, I think that looks better for you guys. Make sure everything else is good. Got it. Okay, let's see. Makes it kind of hard for me to read when we're this zoomed in. Where did... Hang on. Zoom back out for a second. We must have clicked on something. Ah, there we go. I was like, wait a second, where'd our article go? All right, let's see here. So, actually, I'm struggling to read the article and that's zoomed in. So basically this article, first of all, let's talk about what this article is. They use YouTube videos and internet video databases to basically find episodes of head injury that resulted in loss of consciousness. And then what they did is they collected data by looking for fencing response to compare. It looks like adult. They basically instituted mild brain injuries in a cohort of adult male rats and looked for basically the rat version of a fencing response and compared whether or not the fencing response is related to severity of brain injury. And basically what they're finding is I believe their conclusion, if I'm recalling correctly, is that once you exhibit a fencing response, the likelihood of your traumatic brain injury being in the moderate to severe category is significantly higher than it just being a mild traumatic brain injury. And let's see if we can confirm that. They had some nice figures here that kind of show what this fencing response is. So this is kind of this is a nice little diagram right here. So this is, obviously they're just showing, somebody sustains a traumatic brain injury. They go into this fencing posture where, similar to the infant fencing pose, right? One arm is bent, the other is extended out. And what they're doing is looking at, where's the scrolling. They had figures here. I don't know where they went. Oh, here. This is how they're looking at after instituting brain injury, and this is over a time period. So, very initially you get this sort of bent arm, extended arm, bent arm, and then the arms sort of level out a little bit. And then this is preceding the injury. So injury happens right about here. The arms sort of open up, and then one arm starts to collapse into the fencing pose. The other arm kind of extends, and then the arms, everything sort of, this is the thing I found kind of interesting. and you know the arms sort of contract. And you're probably wondering, like, why are we getting fixated? Oh, sorry. Why are we getting fixated on the actual motor response of fencing? Because when I saw this comment from this guy that this is a fencing response, watching the video. Actually, did we put the video? I think I closed the videos. I want to pull the video back up. Video with fencing response here. Let's mute this for a second. Go full screen. We're gonna do free advertising for USAA again. While USAA is plugging themselves, I'm gonna plug us to USAA. USAA, if you're out there, I've used your insurance since day one of being an enlisted Marine. If you want to sponsor this stream, let me know. I'd be happy to do it. Okay, so we get to, let's just fast forward here to the scariest scene, I think, of the entire injury, that at least for most people, and probably our thumbnail, right about here, right? So this is that posturing the NFL protocol is talking about. He's bringing his hands to his head, he's curling down. This arm starts to extend a little bit, not terrible, okay? And obviously they're constantly cutting the camera, so it's hard to really see what his full motor response is. But, looking at the timeline of this graphic, right? This motor response happens over a period of 15 seconds, right? So it's a pretty quick period of time that you see this very important but telltale sign of more severe brain injury. And so where is this right here? So this is the scene everybody sees. That like his fingers are all contorted, his elbows are in. When I initially saw this, I was like, how is this, like, how is a medical expert saying this is a fencing posture? Well, I think what we're actually looking at here is the end phase of the fencing posture, right? If you compare this to, we go side by side here. Hang on, we go here. No, what's going on here? Well, let's pull this up. Where'd that graphic go? Let's pull that back up. Where'd our figures go? Oh, it collapsed. Here we go, right? You compare these phases of the fencing response, I think that's what you're starting to see here. So, obviously, put these side by side. These are not terribly different, I think, from a motor perspective. Again, right, this is a little bit like reading tea leaves. Some medical expert says this is a fencing response. Then you say, okay, what's a fencing response? You start looking into it, and then you start comparing it. You're like, it is. So take it all with a grain of salt. But, this is how, as non-experts, you start to look at the information that's out there, challenge yourself, challenge the information that's out there, and learn new things. And this is really what, the purpose of our stream is, right? I'm not claiming to be an expert on neurotrauma. I'm claiming to be someone who's educated enough to start teaching myself how to be an expert in neurotrauma. And I want you all to see how my brain is working through this stuff in real time as I'm, learning to educate myself. And so, anyway, I'm on board with the diagnosis from CNN's Sanjay Gupta that this is indeed a fencing response. And based on the data from these articles, that tells us that this injury is far more severe than we probably thought. All right. So let's see. What do we want to get into next? I know we're sort of linger. We were in the middle of our going through the protocol, NFL's protocol. So let's go back to this screen. Now let's see. Okay, so we went through all this stuff. Commission, emergency action plan, preseason, educate players, yada, 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 preseason assessment. Okay, this is an important baseline neurologic evaluation. This is very important, right? When you're looking at has something changed, you need to know where it started. And we actually do this in the military as well. I believe, I don't remember the details of it, but I remember undergoing a very interesting neurologic evaluation, basically a battery of questions prior to being deployed to Afghanistan, because they wanted to make sure they had a baseline on everyone before you go, so that way when you come back or if you sustain an injury in theater, they have something to compare it to. And actually a lot of this work in concussion started with the military, and I think has become obviously a little more mainstream with the NFL. Let's see. Blah, blah. This just goes over the details of how they do their pre-concussion testing. Okay, so this question came up earlier. Who is an unaffiliated neurotrauma consultant? A physician who is impartial and independent from any club. Okay, so they can't work for the teams. Board certified in neurology, emergency medicine, physical medicine and rehabilitation, or any primary care, CAQ, sports medicine certified physician, or board eligible or board certified in neurological surgery, has documented competence and experience in the treatment of acute head injuries. Okay, this is great. So this now tells us what that unaffiliated independent neurotrauma specialist, it seems very vague actually, is. So it is not a physical therapist, it is not an occupational therapist, it is not a medical doctor adjacent person, it does not seem that they are nurse practitioners or physician assistants, not that any of those people wouldn't be capable. I'm not here to say whether they would or not. I'm just saying simply they are taking board certified or board eligible, basically means post residency, but they have not amassed enough cases to actually sit for their board. So board eligible basically just means a slightly less experienced attending physician. But they are, neurology, emergency medicine. These are all, various specialties that interact with traumatic brain injury at different phases of treatment. So it's you can't really say a neurologist or emergency medicine, PM&R, which is physical medicine. You can't really say either one's better than the other. They all do very different things. But I would say that it's probably hard to say that they're interchangeable. So I am kind of curious, can any of these people fill the initial evaluator's role? That's hard to say because they have very different roles in the treatment pathway of traumatic brain injury, that they have very differing opinions. Or are they evaluated by one of each of these people? I mean, I wouldn't put it past the NFL with all their resources to be able to do that. But, I would imagine, if you took one neurologist, you took an emergency medicine physician, a PM&R physician, a neurosurgeon, or a sports medicine certified primary care doctor. You took one from every specialty, who I'm sure is an expert in their own right. You put them all, had them all evaluate the exact same patient. They're going to have, I'm not going to say a different, they're not necessarily, maybe this is the most important thing. They might not necessarily have a different outcome, but they're going to have a very different mental framework for how they think about that patient. And from my experience, right, in the neurosurgery world, you see traumatic brain injury, and generally your thought process based on where you insert yourself in this care process is this traumatic brain injury going to get worse? Is the patient's brain going to swell? Is the patient going to decline if they are not treated aggressively in an ICU? Generally, if the answers to those questions are no, no, and no, and you go, the likelihood of this patient ever needing surgery to treat their trauma is very, very low, generally you say the role for neurosurgery is not very high. And so you default to the trauma surgeons, the neurologists, the emergency medicine doctors, the PM&R physicians to let them typically manage things. So when you have someone that thinks that distinctly, they're going to have a different opinion when evaluating the same injury. So I don't know what the role is of these different specialties and where they sort of plug into the NFL's concussion protocol. Anyway, we've sort of perseverated on that quite a bit. Let's see, what else? These are kind of more logistical details. I don't think super important. Another player in the locker room. I see. The club physician may request to conduct the assessment with the second sideline who is present on the opposing team's sideline. Okay, whatever. You assign stadium booth access, multiple views of the video, replay to aid in the recognition of brain, be co-located with the booth. TC spotter. So this is where I would say there's no way, whoever was in the booth, there's no way they missed the motor deficits of the initial injury. If they did, I don't know what they're doing. Then the question becomes, why did they think that he was appropriate to go back to play? I don't know the answer to that question. I don't know that we'll ever know the answer to that question. See, when the booth observes a player is clearly unstable. If you could see like a track changes of this document, I've got to imagine this is an added statement. Because I think that was my personal opinion, that was the biggest thing that was missed. You have... All right. Booth certified athletic trainer spotter. Assigned to each club position in the stadium booth, access to multiple views. So you also have a sports trainer looking for these injuries, which I'm sure they would be more than capable of identifying these injuries. So you've got multiple eyes. I mean, I can understand why, with this protocol in place, people are saying, like, how did a player like this, like, slip through the process? It's hard to wrap your brain around, that's for sure. Okay. Visiting team medical liaison. Board certified licensed physician to practice medicine in the state in which the stadium is located, and who work with the visiting team to provide medical care for its players. Oh, I see. Okay, whatever. So it's just a physician from, you know, if New York goes to California, they need a California licensed physician to take care of the visiting team. Got it. Makes sense. Pre-game medical team meeting. 60 minutes, all medical staff meet with the referees in the locker room. Oh, interesting. No-go signs and symptoms. Okay, this seems like a very important section for what happened, right? Because from my opinion, without having read this, after the first injury, there were no-go symptoms. So, let's see, what do they say? A player exhibits reports any signs, feeling, or symptoms of concussion must be removed immediately, transported to the locker room, neutral sideline observer, or member of the player's club. Observes a player, exits, receives a report of the player's experience. Any of the following signs or symptoms, player shall be considered to have suffered a concussion and may not return to participation on the same day under any circumstance. Okay, so the most important thing in this paragraph to me, if you are diagnosed with a concussion, period, there is no circumstance in which you are allowed to return to play on the same day. It doesn't matter if you have a concussion that is insignificant. I'm sorry, I should never say insignificant. There's no such thing as an insignificant concussion. It doesn't matter if you have a concussion that is, I would say, extremely mild to the point where there's no neurologic deficit. Because you can diagnose a concussion without a neurologic deficit. If anybody diagnoses you with a concussion, you can't return to play. Now, I don't think there should have been any question in the matter of whether or not he was diagnosed with a concussion because Tua had motor deficits. So he should have immediately been pulled from play based on this sentence of the concussion protocol, in my opinion. Because I don't think there's any way. You have to say he's not. You have to diagnose him as being not concussed. I don't know how anybody can diagnose him as not concussed based on video footage available. That's my personal opinion. Loss of consciousness, ataxia, like right, abnormality of balance, stability, motor coordination, dysfunctional. This is it right here. I mean, obviously I'm biased, and I'm looking at this through the lens of knowing what happened, but if I was evaluating the patient, I mean, what did they say? His motor instability was because of his spine, not his brain? So it's not a concussion? Like, is that how they got, is that their loophole? Now, don't get me wrong. I'm not putting all the blame on, you know, the evaluators. I believe in the bottom of my heart, the players fight to not get pulled out of the game. Why? Because they're all team people. Team people will literally let their body fall apart before they let the team down. No one understands that more than someone who has been deployed in a combat zone with a team of other people, right? These are a team of people who will literally die for the good of the team. So, pulling a player, or, you know, in the case of military service, which it's not really the focus of what we're doing today, but we have plenty of stuff to talk about military brain injuries coming up. I believe Thursday, we're going to be talking about similar injuries, but in a military setting, with a couple of guys that I was deployed with who had some injuries of their own. We're going to talk about, sort of focus more on blast injury and research coming from more of the military application side of things. That's Thursday, 12 noon, don't miss it. But, I mean, this is, I don't know. I'm struggling to find, like, honestly, I was kind of thinking, so far things are very detailed. When I specifically did not review the NFL concussion protocol prior to today's live stream, it's because I thought we were going to find a lot of loopholes and, like, well, if this, then that, and, you know, a lot of, you know, because brain, especially mild brain injury, I mean, one of the things that they talk about in brain injury medicine, which is basically like a gold standard reference, where I have a lot of book chapters printed out from this, is especially the biggest issue in mild traumatic brain injury is that it goes undetected. And it either goes undetected because patients don't want the hassle of being evaluated because it seems like a very minor injury. But in the case of controlled populations, essentially military and athletes, there should never be a barrier of seeking medical care because you're actively being monitored by healthcare professionals. So I expected there to be a lot more areas left for interpretation that might lead to loopholes. I just don't see the loopholes. I don't know how somebody goes. I don't see it. That's my personal opinion so far. I'm becoming more and more convinced that this gaffe, which I thought, whatever, maybe it was a minor gaffe, is like a bigger oversight by whichever pieces of the puzzle allowed for to get through not just one, but make it to have a repeat injury, which the research tells us repeat injuries are significantly worse than initial insults, right? The initial insult's done. The damage is done. You know, there's no real true treatment for a concussion other than rest at that point. You know, there's other things you can do to help with symptoms, symptomatic management post-concussion, but there's really nothing you can do to treat a concussion other than rest. That's generally standard dogma surrounding mild TBI concussion treatment. So the goal is to identify and get that person to a place where they are resting and they are healing. But if you don't, and that patient undergoes a subsequent injury, the likelihood of that injury being more severe, like you could look at it in terms of ratio, mechanism of injury, like how did the injury happen, right? Like somebody gets in a really bad car accident. That's a really severe mechanism of injury, right? It's very logical to be like they should have a very high, a high degree of traumatic brain injury, right? The ratio of injury severity to mechanism of injury severity is very logical, right? But once you start getting into that second brain injury, the ratio, you know, takes very much more minor mechanisms of injury to result in much higher severity of injuries. And so I think that's, you know, I really believe that's the goal should be to prevent that second injury from ever happening. But clearly, in this case, everyone in this young man's life, I'm sure he's not totally innocent. I'm sure I would be very hard pressed to believe that he did not want to play and was fighting to keep himself out of the game. But, also what the literature says, I'm pointing to this right here, the literature says that very often the worst advocate for a patient with a mild traumatic brain injury is the patient themselves, right? They are really deemed poor advocates of their own injury. And so it's, imperative that those around the person, the independent evaluators, the coaches, the training staff, the team owners, the league, the player, and I suspect that's what the players' union's fighting for, right? They want all these people to be an advocate for the player. Anyway, let's see. Focused neurologic exam. Now it's getting into, this is the sideline concussion assessment. So this is, someone needs to go for sideline evaluation. What are they doing? Okay, so do they have any no-go criteria? We just talked about no-go criteria forever. Concussion signs and symptoms, Maddox questions, which is just a prescribed battery of questions. Video review of the injury. I mean, they're literally saying that the sideline concussion assessment includes video review of the injury. So again, I raised the question, the question we'll never get an answer to, but the question I'll keep raising: how were motor deficits after the initial injury missed? And focused neurologic exam. There's a lot of nuance to a neurologic exam. But this is a piece of the puzzle that's not really being focused on, but cervical spine examination. And I had this in my sort of planned discussion topics because after the second injury, he was brought off on a backboard. And it's just a general trauma consideration that was impressed upon me by one of my chiefs, was you get so wrapped up in the brain injury, the head injury, that you completely forget about the spine. You cannot forget about someone's neck, someone's spine, when evaluating for a head injury. Because if the mechanism of the injury is bad enough to cause brain damage, is definitely bad enough to cause injury to the spine. And what you don't want to do is be jerking a patient around, trying to, rush them in for care for their brain, and then making them paralyzed in the process when, that wasn't even part of their initial injury. So evaluate. So you need to be cleared. Your cervical spine needs to be cleared, which is a whole nother discussion. I don't think, maybe we'll get into it. We'll see how things go. But we may hold off on getting into it. Eye movements, pupillary exam. Okay. These are all, technical nuances of a neuro exam. Interesting from a provider perspective. Probably not very applicable from the non-healthcare provider perspective. Let's see. Involvement in sideline concussion, club physician, consults in private, members of his or her team, designated identified donors to treat concussed players, sideline UNC, and as necessary, club's ATZ prior to making. Okay, these are just logistics of how things go through their assessment protocol on the sideline. If a club physician determines that a player shall not return to play. So they just yank a player. They don't need to do a complete okay, fine. Clearly that's not what happened in this situation. Club physician remains responsible for all final decisions regarding return to play. However, club physician will consult with his or her sideline UNC team member prior to reaching his or her decision. Disagrees with club remove the athlete, sideline UNC will be given an opportunity to explain the basis of his or her opinion. This will be discussed in a collegial fashion in private as to what the player should have shown. The club physician will communicate. Hold on. The club physician? So this is someone with an affiliate to the organization. Ultimately makes the final decision. What the heck is that? Hold on. Who's the club physician? We need to define that person. Why are they not coming up? Where's the section on personnel? Definitions, responsible. Unaffiliated neurotrauma consultant. Okay, we discussed that. Certified athletic trainer. Hold on. Okay. Now this is the part of reviewing the protocol that this seems juicy. Hold on. Locker room, comprehensive. Sideline. The club physician remains responsible for all final decisions regarding return to play. UNC, this will be discussed in a collegial fashion in private. Like this is collegial fashion. Why? Because if the protocol said it had to be discussed in an unprofessional fashion, that they just start yelling at each other. Why do we, like, that's stupid. Okay. I'm working based off my best understanding, but what this says is that a physician employed by the football club ultimately makes the final decision. So the opinion of the unaffiliated neurotrauma consultant only matters if the club physician decides it matters. Either I don't understand it, or this right here is the fundamental flaw in the NFL's concussion protocol. Why even have an unaffiliated neurotrauma consultant if you have somebody with the biased best interests of the club's success who may or may not care about the player as an individual if they are the ones who make the final decision? That's like, you might as well just tell Jerry Jones he gets to decide if somebody from his football club gets pulled off the field. Now, I know traditionally he's considered an owner who cares very deeply for his players, but I mean, clearly the man thinks in terms of dollars and cents. I don't know. It's possible I'm not interpreting this correctly, but based on how I'm interpreting this, if that's correct, then the protocol is that's insane. Okay. Locker room comprehensive concussion assessment. Okay. Let me just check in with my production team real quick. I think so far we're good. Okay. Sorry, the moderator chat on the side caught my attention. Let's see. Okay, so now we've moved from the sideline assessment into the locker room assessment. Locker room comprehensive concussion assessment to the baseline information. So now they're not just doing, now they're comparing apples to apples. They're basically saying, we're going to see how this compares to their preseason cognitive assessment. Club shall maintain upload, EMR, all NFL locker room, comprehensive, okay, whatever. Logistics. Club physician responsible for concussion evaluation in all circumstances. The club physician responsible for concussion evaluation shall assess the player in conjunction with sideline UNC. Club physician shall be responsible for determining whether the player is diagnosed as having a concussion. The club physician is responsible for determining whether the player is diagnosed as having a concussion. Like, do I not understand who the club physician is? Why do we have unaffiliated neurotrauma consultants if the club physicians are responsible for determining everything? I don't know. Either we're onto something or I fundamentally don't understand. I don't know. Athlete may have a concussion despite being able to complete NFL blah, 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 blah within normal limits. Athlete may have a concussion despite being able to, yeah, exactly. due to potential limitations of the assessment. 100%. 100% agree. This is the most agreeable sentence in the entire protocol. Underscore the importance of knowing the athlete and the subtle deficits in their personality and behaviors that can occur with concussive injury. Agree. This is the most important paragraph in the entire protocol. Why? Let's see, where was it? I highlighted this earlier this morning when I was reviewing this article. Let's see. Providers should attend to both what the patient says and how the patient answers the questions. Let's see. Something separate. Okay, so I don't want to get into the details, but basically there's this. This part of the article is going through a bunch of different parts of basically the development of different assessment tools in concussions and mild traumatic brain injury. And what they say is 80% of patients with mild TBI who failed this, new fancy assessment tool had a conventional GCS score of 15. GCS, meaning Glasgow Coma Scale, is like a very rough, very crude measure of basically brain injury that basically EMTs, paramedics, trauma surgeons use to very quickly communicate, is this a patient who's dying or is this a patient who's, wide awake and talking to you? It does not tell you, it tells you both a lot of information and not a lot of information, but so I don't want to get into the details of it. A low GCS score is very bad. Score of 15 is basically a normal person. Like somebody would say, I am a GCS of 15. It's not uncommon when somebody gets so angry, they start mumbling their words, you can't understand anything. You say, oh my gosh, they're losing their GCS score. A little neuro humor for you. But generally, a patient who's awake, they're talking, they're moving everything, they're doing everything. A person who's doing all the things that a person is supposed to be doing, they're GCS of 15. And so what they're saying is a patient can have with a brain injury, it is proven, the data tells us, a patient with a GCS score of 15, meaning from what you can see, they are a completely normal and intact person. When you dig into the subtleties, i.e. not just what they're saying, but how they are saying it, that's when you start to really break down undetected types of very mild traumatic brain injuries. So that little rant, that's basically all I'm saying. They can be able to complete a comprehensive concussion assessment, which I fully believe Tua probably did. But they're saying the limitations of the assessment are limited. And based on the limitations that they can, so basically they say even if a player passes all of the tests, if deemed appropriate, they can still say you have a concussion and you can't go back to play, because as soon as you have a concussion based on the prior part of the protocol, you can't go back to play. Yet the ultimate decision of return to play is being made by a club physician, which based on our current understanding, unless somebody, I don't know, somebody in chat, please correct me if I'm wrong. Somebody look this up, find out who this club physician is. Tell me if the club physician is not an employee of the ball club. But if you ask me, you have this unaffiliated neurotrauma consultant and basically Jerry Jones deciding if a player goes back to play. And Jerry Jones has the ability to veto anything the unaffiliated neurotrauma consultant has or says. And yet in this article, where they go through all the scandal of, Tua was injured and he was evaluated, allowed to go back to play, and then gets injured again, and now it's so bad, and, woe is us, and we need to reevaluate the protocol. Well, the person who ultimately made that decision to allow him to go back to play, regardless of what the unaffiliated neurotrauma consultant is somebody who's employed by the club. Unless I'm wrong. I will keep saying it. I could be wrong. But based on what this protocol says, that's crazy. It's just crazy. All right. Let's see. Medical timeout. I don't think anybody here really cares about that. It's not really relevant to the discussion. I'm going to skip it. Madden rule. Okay, that sounds cool. On game day, per the Madden rule, a player diagnosed with a concussion must be removed from the field of play and observed in the locker room by qualified medical personnel. Okay. Madden rule is intended to protect the players by providing a quiet environment with appropriate medical supervision to permit the player time to recover without distraction. Oh, I see. Player diagnosed with concussion must be removed from field of play and observed in the locker room by qualified medical personnel. Oh, I see. Suspected concussion. He is not permitted to meet or talk to the press until he is medically cleared. Player is not permitted to drive on the day of injury. This is good. This is basically saying, I don't know all the details. I'm sure these guys, the only reason it's on my radar is because of all the stuff that used to happen with Marshawn Lynch when he say, oh, I'm only here so I don't get fined. Clearly these players are made to do things that they don't want to do or don't always feel up for doing. I'm sure many of them enjoy doing it many of the times, otherwise they'd probably retire earlier rather than later. But typically when you have a head injury, you probably don't feel like doing any of these things. And so there's old Madden protecting the players. Brings back memories of all the Sega Genesis Madden lines. All right, let's see. Additional evaluations and follow-up. I don't really want to get into that stuff. NFL concussion game day checklist. This should be interesting. Okay. Intended to provide a clear summary of the steps required by NFL head, neck, and spine committees, concussion diagnosis and management protocol with regard both to sideline survey and locker room exam. NFL concussion game day checklist attachment D is incorporated herein by reference. Application NFL concussion game day checklist to evaluate potential concussions during NFL preseason and regular season games is mandatory. Designated medical personnel, club physician, athletic trainers, sideline booth, UNC's booth, ATC spotters must complete their designated steps. NFL concussion game day checklist, blah, blah, yada, yada, yada. Okay, whatever. Nothing important there. Hold on, I'm getting all fired up here. No. Concussion subject to their club. May subject their club to discipline. Okay, whatever. Return to participation protocol. I think this is probably pretty important because obviously 2-0 went through some sort of protocol. I mean, so there's two issues, right? The first issue is why was he allowed to return to play on the same day? The only way that happens if he is distinctly not diagnosed with a concussion, right? So clearly he must not have been. If he was diagnosed with a concussion, or I'm sorry, if he was not diagnosed with a concussion, or hold on, back this up. If he was diagnosed with a concussion, pulled out of the game initially, and then returned to play the following week, that could possibly... That was obviously not the scenario that happened, but at least if that was the scenario that happened, I can kind of see where you might, now you have a return to participation protocol, there could be things that are less clear in that protocol that allowed him to get back into play. However, it's largely a moot point because he went back to play the same day, so he was not even diagnosed with a concussion. Each player and each concussion is unique, okay, yeah. No set time frame for return. Recovery time will vary from player to player. Agree. Decision to return a player. Participation remains within professional judgment of the head club physician. Participate. Hold on. Hold on. Are we missing some stuff in the chat? Oh, hang on. We must be missing a few. My production team's forwarding some chat questions that looks like are not coming through on my end. So hold on. Let's pause here. Let me answer a couple of chat questions real quick. So we apologize for the technical difficulties. Obviously, we're just sorting through a lot of this stuff. Things like chat and, you know, a lot of, we'll get better at it. We promise. Just keep tuning in. We'll make the show better. So the question is, I have two questions. Boxing and MMA would also be a fairly controlled population and would be fascinating to do the same analysis on. I agree. I mean, in general, right, when you're talking about studying traumatic brain injury, you can study it in sports and you can study it in the military. And when you look at the literature, that's basically where we see traumatic brain injury being studied. And it makes sense, right? Because these are populations where you can see the natural history of the disease from the time that it's identified to whatever the end point of that disease is. And that's a big theme in just general research as a whole, is at what point are you able to start studying the disease, right? If a disease goes undetected for 10, 15, 20 years before it becomes a problem for patients or even identified, right? The questions you have to start asking is, how do we get ahead of that 10, 15, 20 year time period? And that's where screening and all this kind of, you know, advances come in. I mean, people used to, you know, when people would take colon cancer as an example, right? You always hear, oh, you got to get your colonoscopy and, you know, all these things. Like, there's protocols in place for when you're supposed to start getting them, how often you're supposed to start getting them, because the data says that if you identify neoplastic elements on a colonoscopy early and you intervene early, you can prevent progression of the disease. Well, before any of that stuff existed, all you had was progression of the disease that led to people dying and brought people into healthcare, right? Like, people needed progressive disease to be brought into the hospital and identified. So then when you start having these years and years and years of lead time, you need to get ahead of that lead time. In the case of colon cancer, it was, you know, it's been colonoscopies, and now it's getting into, you know, I think DNA testing kits where they can really just use stool samples. I don't know all the details. I'm not a gastroenterologist, nor would I ever want to be one. But no offense to the GI doctors out there. It's just when I chose to be a brain doctor, one of the cited reasons for that was because brains don't poop. And that is a very true reason to today. I did not want to deal with an organ system that pooped. Not my cup of tea. That's okay. A lot of people hate the brain for their own reasons, and that's okay. They're allowed to. I don't take it personally. And so that's for those reasons. The fact that you don't have to, you know, we have this huge problem of identifying patients with traumatic brain injuries and getting them to a place where we can help them and study them. We have no idea what's happening, right? If these numbers are correct, let's see, what do they say? 8 million mild TBIs in the United States a year. 1.3 million actually get reported through the CDC. Well, that is, I don't know, do some rough, we'll just round down. That's basically 1/8. 1/8 of, right, is my math correct? I believe 1/8, right? 1/8 of mild TBIs are actually being detected. So in order to start addressing the issue of mild TBI, you have to ask yourself, how do we capture the other 7/8? That way we actually know what are the problems and what do we need to do to address it. Or you can basically then, you can go one degree even further, which is kind of more where TBI intervention comes into play. How do you just prevent that other 7/8 from even happening? But going back to the original question, boxing and MMA, also a controlled population, great population that is studied, should continue to be studied, and honestly, we'll do another live episode where, you know, we continue this conversation about traumatic brain injury, except instead of looking at it through the lens of the NFL, we could probably look at it through the lens of UFC and mixed martial arts. I mean, obviously, not many people know this about me, but when I was enlisted in the Marine Corps, I spent about 6 months fighting professionally in mixed martial arts for the Marine Corps. Did a few tournaments in Vegas, and that used to be my life. What I did full time for the Marine Corps was mixed martial arts. I'd get up in the morning, I'd go for a run on my own, then I'd eat some breakfast, I'd head into the base gym, train there for about 4 hours, go home, shower up, have a meal, go out for an evening training session at my own private gym, and on the weekends I would compete for the Marine Corps. I was very involved in mixed martial arts, so I think looking at sort of what that community is doing that parallels this protocol would actually be very, very interesting. So yeah, we'll definitely look at that. And then this same person, I believe, is asking, is there a biomarker that can be used to monitor the span and resolution of a concussion? Help reduce risk of post-concussion syndrome. A biomarker? Not that I know of, but again, I don't know. I would like to get more into biomarkers and sort of where the scientific, sort of the bench laboratory research is at. So we'll definitely do that as we go forward. I'm going to jot a couple things down, because as you guys are coming up with stuff in the chat, I want to make sure we put together shows and episodes that, we go through all this stuff. Let's say biomarkers. TBI. Can definitely make that happen. MMA. TBI. All right, so we'll definitely look into that stuff. And hit us up in the chat. I apologize, the chat is for whatever reason not working, and we will get that figured out. I thought all this time chat was just kind of being quiet, but reality is my production team is telling me chat is firing away with questions, and I'm just not seeing them. So I do sincerely apologize for that. So, stick your questions in the chat. Carlos, our production manager, will definitely make sure that your questions get read and answered. If you miss the answer live, everything is going to be, post-produced, available on YouTube. You can watch the full stream after we're offline. We'll put shorts up so you can see the highlights really easy. We're going to make this real fun. So questions you have, ideas, things you want to talk about on stream, put them in the chat. Tell us what you're interested in. We're going to make it happen. We're live every Tuesday, every Thursday, starting at 12 noon. Every day, every Tuesday and Thursday for now will be myself, Dr. Rad, but really because our focus is growing the reach of Brain and Spine Group as an organization. This is not a show about me and my ego. In fact, I think focusing on the organization was probably the number one thing I said with the team when we started talking about live streaming. And I told them I don't want a live stream that's about, me and Dr. Rad, like a lot of social media doctors out there. I want to do it because it's fun, but I want the focus to be on our organization, because our organization is an amazing team. Tons of volunteers. They're so passionate about brain and spine health. And as we go forward, we're definitely going to get shows together on Tuesdays and Thursdays with other people from the organization that bring a totally different perspective than what I do. And a lot of that stuff's already in the works. You're going to hear about it as weeks go on. So please hit us up in the chat. Tell us what you're interested in so that we can make that happen for you. All right. So let's pick up where we left off so we can start moving towards an end point here. We sort of I wanted to dive into the NFL protocol heavily, but I've also got tons of other stuff to get to. I'm just flipping over to our notes here, see what else we have to cover today. Yeah, okay. So let's see. One more sip of water and let's get into it. So we're currently looking at the return to participation protocol. We're right back on the same soapbox I've been on about the head club physician or club physician being the one that is making these decisions. I mean, the return to play being, and honestly, chat, look this up for me and let me know. Because I genuinely want to know, and chat can help us figure this out. Is this club physician that they keep talking about being the one that's ultimately making the final decision? Is this somebody that's employed by NFL football clubs? Because if it is, I mean, that's a problem. Although, apparently, our organization's legal advisor is telling me I'm not allowed to reference the NFL. I don't know if that's a thing or not. I don't think we're that big. Or should we just take the Pat McAfee show approach? The American Professional Football League, we're looking at the concussion protocol that was developed by a professional football league in the United States of America. Anyway, somebody in chat, help us out. Find out if this club physician is employed by the clubs of the American Professional Football League. Let's see. Let's see. Final phase, return to participation protocol. Let's see. Okay. After a player patient, oh, that's nice. Now they're starting to refer to players both as patients. They're not just players. Okay, that's good. They're also people. If a player patient's been diagnosed with a concussion, he must be monitored daily and more frequently if clinically indicated in the opinion of the club physician through the return to participation protocol described below. That's what I'm most interested in. I think we're just flipping through logistics. I'm going to scroll down to here. This is what I want to see. I don't care about all the logistics. Even though so far the biggest issue we found is kind of in the logistics. It's not in the protocol itself. So far the protocol seems spot on. It's exactly what I would expect. The issues we found is the logistics of the protocol and how it's implemented. That's where we really, so far I've found the problem. At least what I think is a problem. I guess time and a little further digging will help us get to the bottom of whether or not this is a problem, an actual problem or a misunderstanding of who these people actually are. Again, my whole qualm with everything could be a giant misunderstanding. I acknowledge that. I do not want to see clips going viral. I mean, you can send clips viral, but I don't want to see misrepresentation clips going viral about me saying the NFL's all messed up if in fact, it's just a misunderstanding of what they're saying. Let's see. Player patient prescribe rest, limiting, or if necessary, avoiding activities. So this is exactly what we're saying. There's really no true treatment for concussion. There's no real... Okay, so rest. Rest is the only thing you can do. Rest and addressing symptomatic treatment, which is not actually improving the healing of the brain. It's simply improving your ability to deal with the pain or discomfort or whatever symptom you're dealing with while the brain heals on its own. That being said, I will shamelessly plug my wife's practice. She's an amazing chiropractic physician. Her practice, Vital Brain and Spine, if you're in the New York, New Jersey, Pennsylvania tri-state area, and you have had a mild traumatic brain injury or a concussion, and you have been medically evaluated, and you are simply in the recovery phase, but you're dealing with things like headaches, neck aches, please consider evaluation. Her clinic, Vital Brain and Spine in Branchburg, New Jersey, they deal with tons of patients and post-concussive syndrome. And again, right, they're not treating the concussion. The brain needs time to heal. That's how you treat a concussion. But they are very, very experienced in helping you manage the symptoms related to post-concussive syndrome. Vital Brain and Spine, Branchburg, New Jersey. They do not pay me for advertising. However, obviously I'm biased given that my wife is a fantastic chiropractic physician, and I'm more than happy to promote her practice. Let's see here. Phase 1, light aerobic activity. Okay, blah, 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 blah. Yada, yada, yada. Should additional medical issues present, club physicians should consider external consultation or additional diagnostic examination. Again, I mean, this all hinges on who this person is. This person, the club physician, and their relationship to the club, if it is financial in any way, changes everything I've read, for good or for bad, depending on their relationship to the club. Right? Physicians aren't dummies. Right? If you're biased and you want a player to return to play, you'll consider external consultation or diagnostic exams that are going to support your end goal. Not necessarily the best interest of the patient. Is that the ethical thing to do? No. I don't think anybody would argue it's not the ethical thing to do. But that's the whole point of bias. The whole point of bias is that you really can't You can't just decide not to be biased. All you can do is declare it. You can say, I am biased. Right? So if there is motivation for this person to act in the best interest of them or the club that is employing them, and not in the best interest of the player-patient, well, the player-patient is totally at the mercy of this person to do what's best, or, to recommend what's best for them. I don't know. To me, it just seems crazy. Does not show signs of concussion on neurology. He may be cleared to proceed to the next phase. So if a player does not experience an increase in his symptoms and does not develop signs of concussion on neurologic exam, meaning he's got a clean neuro exam, again, doesn't necessarily mean, like we said, you can have a perfect neurologic exam with very subtle indications of a concussion. That being said, I would expect those subtle indications of a concussion to persist for an extended period of time. I don't know. So basically, after they clear their initial limited activity, clean bill of health from a neuro exam, symptoms aren't getting worse, they're clear to proceed to aerobic exercise. Okay. The player should be back to his baseline level of symptoms. Team physician reasonably determines that the symptoms are not related to concussion. Once the player or patient has demonstrated his ability to engage in cardiovascular exercise, that an increase or aggravation of symptoms, his symptom burden is at or below his baseline, he may proceed to the next phase. The symptom burden is at or below baseline. So basically what they're saying is if you're not getting any worse and you're able to tolerate physical activity without getting worse, even if you're not better, you can still proceed to the next phase of the protocol. I mean, maybe. I don't know. I think it's a case by case dependent. And obviously, we're dealing with adult patients. We're not dealing with pediatric patients. They should have some autonomy, which I hope that they would, to determine what what is tolerable and what is not in terms of persistent symptoms. Player or patient continues to supervise cardiovascular exercises that are increased and begin to mimic sport-specific activities, as well as supervised strength training. Player or patient is allowed to practice with the team in a sport-specific exercise 30 minutes, blah, 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 blah. Player or patient should not proceed to contact activities. Neurocognitive testing is back to baseline. Okay. Player or patient demonstrates ability to engage in cardiovascular exercise. Increase aggravation signs and symptoms. Okay, so basically the theme is the same. We're basically saying if you're able to slowly progress in your activity level with your symptoms without them specifically aggravating your symptoms, then you just sort of keep proceeding. The problem I've seen, and I think I've seen, is obviously somewhat applicable in this most recent news case of concussion is that should there be a set period of time, and maybe there is, we just haven't gotten to it yet, but a set period of time in which a player patient cannot proceed through the protocol faster, like a minimum amount of time, or even if they check all the boxes, they can't be back to play by the next week. I don't know. My personal opinion is if you have a diagnosed concussion, even if it's mild, and again, personal opinion, there could be exceptions to this opinion that I'm not thinking of. So I'm not saying I've considered all scenarios and possibilities, but I'm struggling to think of a scenario in which you diagnose a concussion and for the sake of the NFL world functioning on a roughly 7-day calendar, assuming your games are scheduled Sunday to Sunday, obviously Monday Night Football and Thursday night games complicate that, but as a whole, an average of 7 days from game to game, I think if a player is diagnosed with a concussion, I can't imagine there's a great scenario in which a player moves through the protocol and is ready to play in the next game 7 days later. I don't know. I don't know that anybody knows the true answer to that story. That's the individuality of healthcare. Being a doctor, taking care of patients. As soon as you think you've got things down to a protocol where you say it takes this many days for this to happen, somebody walks in the door and proves you wrong. Okay. Non-contact training drills. Exceptions to the neurocognitive component may be considered by the club physician responsible for diagnosis and treatment of concussion in consultation with MPC on a case-by-case basis in player patients with documented ADHD or learning disabilities. Clarity. All signs of neurological, including cognitive balance, must return to baseline. Baseline status before returning to full football activity clearance. That's what I'm talking about. Good. Club-based non-contact training drills. If a player or patient is able to tolerate all football activity without a recurrence of signs, symptoms of concussion, if his neurocognitive testing has returned to baseline, and if symptom burden remains at or below baseline, he may be moved to the next phase in the sequence. So, again, they're saying if your symptoms don't get worse or they're exacerbated, you're okay to move on. But this additional state, testing return to baseline, that's important. Because now you're getting at more, I think this is where you're starting to get to stringent criteria that's starting to really determine if someone is ready to return to play. Because if you just say, if your symptoms aren't getting exacerbated or worse, I think that's too vague. But at least as you're progressing through the phases, they're starting to kind of cinch up the criteria a little bit to make it a little harder to actually progress into full football activity, which I'm encouraged by that. Now let's see. Actual clearance. After a player has established his ability to participate in non-contact football activity, team meetings, conditioning, non-contact practice, without recurrence of signs and symptoms, his neurocognitive testing is back to baseline. The club physician may clear him for full football activity involving contact in practice. Okay. I would probably like to see something in here, data-driven, surrounding, data-driven by what's best from the perspective of recurrent injury. And what does that mean? Because that's kind of a jumble of words. Something data-driven that tells us A player should not return to play, even if they meet all this other criteria, for a minimum of X days. And defining what that X is should be based on risk associated with a repeat injury, right? Because we know, the literature tells us that if you have a second injury in close proximity to an initial injury, that the outcome of that second injury is going to be worse. We know that. The question is how much time in between the first and the second injury is needed before that risk of worse outcome with the second injury really drops off. That's what I think we need to figure out. And I think the question I would have is, has that question been answered in the literature, and is that a question that we should answer? Because I think that would dictate whether or not we establish in a protocol like this a minimum number of days before return to activity should be accomplished. So I'm actually going to jot that down. We're going to look into that. So we're going to see a risk drop-off for second injury lag time. So that's something our research team is going to work on. Big focus of the organization going into the next calendar year. We want to expand our impact on research, and that starts with raising money for research, funding external research projects by physicians and medical students and people out there, helping get them the funds needed to execute their research projects, and launching our own research projects. And any researcher worth his salt will tell you this first step of doing research is having a question. Something that says, what do we need to know that we don't already know? And so a big part of our live stream is looking at neurotrauma out in the real world, like the NFL protocol, and digesting it in an intellectual and academic way, and coming away from that with questions. Questions that we can design research projects around, that we can fund research projects around, that we can use to ultimately improve the future of brain and spine care, which is what we're all about here. So let's go back to, we're getting close to the end here. Let's see. Player, patient tolerates full participation in practice without signs or symptoms of concussion. Player, patient's concussion has resolved. I don't know about that, but concussions take a long time. Symptoms can resolve. The concussion, I'm hard pressed to believe that resolves in such a short period of time. But again, look, I'm not sitting here touting myself as an expert. I'm simply going through the information, learning alongside all of you. And we're going to figure it out. My opinion on that could change by next week as we learn more. And that's what we're going to do. If you disagree, if you think that concussions actually resolve on a much shorter scale, tell me. I want to hear your opinion. All right, let's see. Full contact with other players due to the time of year, rules imposed by a collective bargaining agreement. Simulated contact activity will suffice to satisfy this phase. What is it? For the avoidance of doubt, if a player or patient cannot participate in practice or full contact with other players due to the time of year and or rules imposed by the collective bargaining agreement, simulated contact activity will suffice to satisfy this phase. INC assigned to his club must provide a copy of all relevant reports and tests, including the sideline, booth, UNC reports, booth, ATC spotter report, team injury reports, and have access to video of the injury where applicable and the player patient's neurocognitive test results and interpretation. If INC, I guess this is the independent neurotrauma consultant, confirms the club physician's conclusion that the player patient's concussion has resolved Player patient is considered cleared and may participate in his club's next game or practice. Okay, so this is the big change. So the independent neurotrauma consultant sounds like is ultimately responsible for the clearance of a player once they've been diagnosed with a concussion and put into the concussion protocol. It sounds like basically the concussion, once a concussion, so when we're looking at the NFL's concussion protocol, I'm breaking this down into basically two buckets. You have the protocol for people who are not diagnosed with a concussion, which you have to say was Tua's category that he fell in, because he returned to play the same day. If he was diagnosed with a concussion, he would have, by the protocol, not been allowed to return to play the same day. Possibly return to play the following game. But the fact that he went back into the Bills game means that he was never diagnosed with a concussion. Period. I don't see an alternative point of view there. Because as soon as you diagnose a concussion, the protocol very clearly says you cannot return to play on the same day. So the fact that he went back into the Bills game says he was not diagnosed with a concussion. So there's no real argument that that was the error of their ways. Not diagnosing the concussion initially was the problem. And return to play on the day of the injury in that game is the responsibility of the club physician, not the ultimate responsibility of the independent neurotrauma consultant. The independent neurotrauma consultant consults and informs the team physician or the club physician, but the club physician ultimately decides if a player returns that day. That based on my understanding of the protocol. If I'm wrong, explain to me why I'm wrong in the chat, because I want to understand. Now, so that's the category Tua was in. That was the problem. The club physician, maybe they made a bad decision based on bad consulting advice from the independent neurotrauma consultant, and that's what ultimately led to the independent consultant's expulsion by the Players Association. I don't know. It's all speculation. However, I think based on the video evidence available alone, the patient, it was a misdiagnosis of a concussion initially, and he should have never been allowed to return to play the same day. Now, putting his situation aside and just simply looking at the protocol, the part of the protocol that says once you diagnose the concussion's been diagnosed, now you enter into this category, you become a player patient. Player patients must progress through the full extent of the return to play protocol. The ultimate decision of the return to play protocol, while the protocol is executed, is implemented by the club physician, it seems, for the most part, the person who actually makes the final decision is the independent neurotrauma consultant. In Tua's situation, I don't think you can blame the independent neurotrauma consultant for clearing him to go into the Bengals game, because technically he would have never been in the return to play protocol because he was never initially diagnosed with a concussion. So you see where everything comes down to that initial diagnosis of concussion, at least the way that I'm interpreting the sequence of events. And again, we're only able to understand things to the degree in which we have information provided to us. So if there's information that's not available to me that influenced the outcome of this situation, maybe that's why the way things panned out seems different. But if you take purely how you can see things at surface level, now that we've read through the 20-page document of the NFL's concussion protocol, it's pretty clear to me that I think the initial diagnosis of a concussion was missed. That was the incident that led to the unraveling and ultimately led him into a second game. Because if that diagnosis is made, he is not allowed to return to play that day, regardless of the opinion of the club physician. And if he is diagnosed with a concussion, then he enters into the return to play sequence protocol over that time period between the Bills game and the Bengals game. And then ultimately the person who decides whether or not he goes into the Bengals game or is allowed to play in the Bengals game is the independent neurotrauma consultant. However, I don't think we made it to that point. He was never diagnosed with a concussion. The person who ultimately, by my reading of the NFL protocol, decided that he was clear to return to play that day was the club physician. And from what we can understand, the club physician is an employee of the club who has the best interests of the club, not necessarily the player. Or I have that completely wrong. But I think that pretty much wraps up everything I wanted to cover with the NFL's concussion protocol, all the stuff surrounding this recent injury that's been in the news. And, if you have questions about it, comments, leave them in the chat. Carlos will make sure that they get relayed to me. And let's, I wanted to possibly talk about Tua being brought off on a backboard, clearance of the cervical spine, which we kind of talked about. But you know what? We've got tons of streams coming up where we're going to talk about not just traumatic brain injury, spinal cord injury. We have plenty of time to talk about cervical spine clearance, so we're not going to get into that today. It's 2 o'clock, so we should really start winding down. But next week is going to be, Thursday, the 10th, is the Marine Corps birthday. It's one of the most sacred days of the year in the Marines calendar. It's the day that, November 10th, 1775, that's the day that our Marine Corps came alive. Every Marine loves that day. And I'm going to get together with two of the guys that I deployed to Afghanistan with in 2010. We're gonna just have a good time talking about what that experience was like, how neurotrauma impacts military members. We'll get into a little bit of military research. I was going to possibly do a little primer and discuss some military head injuries this week, but I don't think we have time for that. We'll just wrap things up and we'll dive into military head trauma full speed on Thursday starting at noon Eastern. I think that's 9 Central, 11 Central, 9 Pacific. Nobody cares about mountain time. I think I only know one person that lives in the mountain time zone, and we can all of my friends unanimously agree that nobody cares about them. No, I'm just kidding. If you're in mountain time zone, we love you. We hope you tune in. We're just hassling a friend because we can. So we're going to get into all that stuff. The full stream is going to be available on the YouTube channel. We're going to have shorts and highlights and everything from each and every stream put up for you. Like our channel, subscribe to the channel, forward the videos along to friends, family, donate to Brain and Spine Group so that way we can keep doing more of this stuff. We can make it better. We can get more interesting people. Really, it's exciting what's coming up and what we've managed to do over the last 3 or 4 years in terms of brain and spine education, and we just want to keep that train moving forward, do more and more exciting things. I thank you all so much, so much for being with us today. We apologize for any of the technical difficulties. We are going to get those, worked out with each and every stream. But again, this was an absolute blast. Neurotrauma has been my passion since the day I decided I wanted to be a doctor. When I got out of the Marine Corps, I saw the head injuries, the spine injuries, and I didn't see a medical community out there that was really trying to move it forward. And so I decided that's what I want to do, and that's what I'm here to do. And you know what? If neurotrauma is not your thing, we've got tons of educational initiatives that we'll be talking about. We're going to get additional people coming in, streaming for Brain and Spine Group that have totally different passions. Tumors, aneurysms, functional stuff, epilepsy, Parkinson's disease. These are all things that, important issues that, affect everybody on a deep and personal level in one way or another that, we want people who are passionate about those things to come and talk to you about them. So join us on the streams every Tuesday, every Thursday. thank you so much for your time today. Carlos, do we have any last minute questions before we wrap it up? I think we're good if I'm not seeing anything. All right, I'm getting the thumbs up that we're all good. So thank you, and we'll see you Thursday at